Good afternoon, everybody. My name is Dr. Hart Beatty. I'd like to welcome everybody to today's session of the APDR National Virtual Noon Conference. I'm delighted to have two great speakers speaking on neuroimaging today. Just a few housekeeping items as we go through every session. As you know, the webinar is being recorded and it will be hosted on the APDR YouTube channel within a few days. We ask that in addition to the webinar being recorded, all questions and comments are being recorded. The microphones for the attendees are muted to ensure optimal quality. And we ask that if you do have questions for the presenters during their talks, that you use the question and answer tool on the Zoom platform. And if we can't get to them live during the session, then we can certainly email those questions to our presenters and they can get back to you. So I'd like to introduce two really amazing speakers today, and two guys I consider friends as well. I'm delighted to have Dr. Mark Mullins and Dr. Will Meehan speaking today in neurotopics. Dr. Mullins will start the session off with inflammatory brain lesions. So without further ado, again, so appreciative and delighted to have Dr. Mullins kick off the session. So I'll stop sharing my screen and invite Mark to start his presentation.
Thanks very much, Harp. This is a fantastic series. I really appreciate you inviting me today. And as Harp said, please feel free to reach out to me via email or hit me up on Twitter if you have a question about this stuff or just want to chat. I'm going to talk about inflammatory brain lesions. This is my conflict of interest slide. I don't think it's relevant to the current presentation. And I'm just going to go into a bit of an overview. It's going to move a little bit quickly considering the amount of time that we have today. I'm not going to do a whole lot of background, but I am going to talk about a little bit of tenets of imaging, protocoling a little bit. The short version of protocoling is to make sure that you focus on the areas and optimize the areas that you want to image. Show you some cases. Everybody wants to see some cases, and I like a pearls and pitfalls approach. Here's a patient with a cluster of white matter lesions in the left frontal lobe. Although this is non-specific, this is one of the appearances of vasculitis/vasculopathy. A few years ago, one of my colleagues pointed out that you can't tell the difference on imaging between vasculitis and vasculopathy. Those are pathological diagnoses in terms of differentiating them. And I thought that was good. So I kind of pivoted to say, whenever I think about saying vasculitis in a report, I'll say vasculitis, vasculopathy. So we'll move on. And the short version is that if you think that infection and inflammation have a very similar appearance, you're not wrong. That's certainly oftentimes the case. If you think about one, think about the other. In terms of protocoling, usually what you're going to end up doing is a brain MRI with and without contrast. Routine usually is quite helpful for this. If you're looking for microhemorrhages, it may behoove you to add on an SWI. Microhemorrhages can be a useful way to identify vasculitis, vasculopathy amongst other etiologies. The post-contrast imaging is typically going to give you a boost in terms of sensitivity and specificity. Not always, but usually. And a long time ago, people looked at the size of lesions within the brain for metastases to try to figure out where's the no man's land, you know? And so the idea is 3 to 5 millimeter size lesions within the brain. Above that size, you probably should see it even if you don't have contrast. Below that size, you're unlikely to see it without contrast. Not the same exactly for infection or inflammation, but we can pull from that and think that's probably going to be useful as a ballpark idea of what to think about. There are going to be certain parts of the body, like the orbits, for example, that if you want to protocol that area, you're going to specifically have some sequences that are optimized for that evaluation. And certainly, if you're used to protocoling MRI, you know what I'm talking about. In general, MRI trumps CT for soft tissue evaluation. Hopefully, you're clear on that. And the two can be very complementary with each other. If you have a process that's changing relatively quickly, then infection and inflammation certainly go much higher on your differential diagnosis as opposed to things that change slowly, although certainly these things can change slowly as well. I like the useful short interval follow-up or follow-up to resolution. So if I'm looking at something and I've exhausted what I can do to sort of try to figure out what it is, whether talk to the patient or do a chart biopsy, look to see what diagnoses they have, maybe there's some other lab results, something like that, I will then think, okay, do I want to follow something up to resolution? Like, for example, I think it's a subacute infarct just to make sure it's not something more sinister, or I'm not sure exactly what this is. And employing kind of the philosophy of the BI-RADS approach, I'm going to do a short interval follow-up and see what that might be. Classic appearance for multiple sclerosis with Dawson's fingers in the white matter. Certainly, there's some overlap in what you might call infectious or neoplastic as to what would be inflammatory, but a lot of them have an inflammatory component. You may not be able to distinguish infection and inflammation off of the imaging. And if you jump to physiologic imaging, like a PET scan, if you jump to a PET scan or a perfusion scan, you might be confused. So a lot of these inflammatory processes can be hypermetabolic, and you might jump down the road of saying it's neoplastic. So be very careful about that. A long time ago, you know, I remember seeing a PET scan for somebody who had combined increased signal and decreased signal. And, you know, that's one thing that makes me think about infection, for example. But you don't always have that mixture, and inflammatory processes can be very, very concerning looking on advanced neuroimaging or nuclear medicine scan. And that reminds me to say that if you're going to use any advanced neuroimaging, whether it be perfusion or what have you, be very, very careful about looking past the conventional neuroimaging to make sure that you don't find yourself in a situation where you're overcalling something based on the advanced neuroimaging. So for example, if you do spectroscopy of tumefactive MS, it may look a lot like a brain tumor, for example. So just be very careful about using the advanced neuroimaging. Here's a patient with rheumatoid meningitis, which is classically enhancement within the subarachnoid space, sometimes leptomeninges, sometimes pachymeningeal as well. I've seen that plenty of times as well, and along the surface of the brain. Definitely non-specific, but in somebody who carries a diagnosis of rheumatoid meningitis, that's one of the typical presentations of this unusual diagnosis. There are lots of things that can do this kind of process, and we're going to go through a few of these here. Here's a short laundry list for this kind of thing, but in general, what we're talking about is breakdown of the blood-brain barrier, leaky vessels, fluid coming from the intravascular compartment into the extravascular compartment, extracellular milieu, and you know, you're going to get some swelling. I'm somebody who splits words a lot. I'm a splitter, so to me, brain swelling is swelling of the brain, straightforward. To me, cerebral edema is increased water within the brain and can, on a CT scan, decrease density, on an MRI, increase T2/flare. So here's somebody with a relatively symmetric process, clearly a white matter process, even though it's secondarily involving deep gray structures, and there's prominent involvement of the brainstem. This patient clinically had an encephalitis. That's one of the things to remember. I learned a long time ago that patients who have some form of an encephalitis ought to be encephalopathic clinically. So you're thinking somebody may have Edema, for example, they ought to be encephalopathic clinically, and that could be useful in terms of differential diagnosis. I don't think we ever figured out what this was exactly, but if you practice enough, you'll see cases of acute necrotizing encephalitis, and you know they're very clinically bad. But the idea is there's probably some underlying viral infection that just has not yet been discerned in that particular patient. So that can be one of those things. Again, I'm a splitter, so cytotoxic, of course, is going to be restricted diffusion and may go on to have that tissue necrose. Vasogenic edema is just increased water content within the brain without restricted diffusion. If you see vasogenic edema, typically it's in response to something else. So if you look at a head CT and see vasogenic edema, the classic look for vasogenic edema would be within the, taking the shape of the white matter and not involving the adjacent cortex. Classically, cytotoxic edema would involve the cortex. Enhancement is a very blunt instrument. It's just simply breakdown of the blood-brain barrier. It depends, it can be affected by a whole lot of things, including corticosteroid use, amongst others. So it's a very blunt instrument, but of course everybody kind of follows it. Patient with acute necrotizing encephalitis, and very hard to see on the CT, but you can see a little bit of decreased density, a little swelling. And this, of course, is getting into the posterior fossa. Once you get into the cerebellum, you start to worry about cerebellitis too. In terms of protocoling, non-contrast head CT is kind of like our stethoscope in America. It's kind of first pass in a lot of cases. This, of course, is an MRI. If the patient can go on to have a brain MRI, I usually don't give contrast for the head CT unless there's some extenuating circumstances. And don't forget that CTA or CTV is not really the standard delay in terms of being able to determine if they're enhancing lesions or not. It's like a different phase, just like when you're looking at liver, that kind of stuff. Here's another patient with acute necrotizing encephalitis and having multifocal lesions in the subcortical white matter with secondary involvement of the cortex as well. In terms of the MRI, like I said, routine brain MRI with and without, you're going to usually add on your usual sequences. Do have some form of a susceptibility weighted sequence to help you out, and be careful about advanced neuroimaging. Here's a patient with carcinoid brain metastasis, and you can see a ton of edema in those frontal lobes, very inflammatory, and this would be a vasogenic edema pattern. There we go. Yeah, so here's a patient with bilateral frontal tumors. This is a patient with multicentric GBM. This patient has NF1. And so, you know, this basically, you know, you're going to have edema patterns, that kind of stuff. The amount of edema is very variable. When you follow people with brain tumors, the edema pattern can be definitely affected by steroids. Steroid treatment is kind of like the dirty little secret of brain tumor imaging. And when I see somebody on a follow-up who has like a decreased edema pattern, that doesn't necessarily mean that the tumor is any better. Usually, to me, what that usually goes along with is steroid use. If you have what looks like a meningioma here and you have edema next to it, this is probably prominent peel arterial collateralization. Every now and then it means the brain is being invaded by the tumor, but this looks pretty sharp on the margin, so probably not, like that kind of thing. So it's probably that. Whenever I ask residents about this or fellows, usually people will say the edema is related to how big it is, but I've seen tiny ones have huge edema and huge ones have tiny edema or no edema. And I learned from the neurosurgeons that there's an increased risk of bleeding and stroke when you have more edema there. And if you'll pardon the pun, it's hard to peel off the brain. So peel arterial collateralization, like that kind of stuff. Of course, I'm looking for those edema patterns, try to figure out what's going on. Edema is one of those signs of acuity. Enhancement is one of those signs of acuity when you're talking about multiple sclerosis. So classically, enhancement would suggest radiographically acute plaque, whereas another thing I look for is swelling, certainly in the spinal cord as well. Restricted diffusion has kind of gone to be one of those things where people are not 100% sure how to say it. Does that mean it's acute plaque or not? But it's something to pay attention to. Certainly these things can be big and have a tumefactive appearance to it. If you think something could be a tumefactive MS lesion, it's a good time to put the brakes on, talk to your friendly neighborhood neurosurgeon, and ask them to consider the possibility that it's MS. So typically we'll work up from there. Sometimes you're going to see a lesion, like you could look at this and think, I wonder if that's a thalamic glioma, got some positive mass effect. It's not isovolumetric. Do a spectroscopy on it. Doesn't look particularly neoplastic on the spectroscopy. And in this case, this patient was also encephalopathic. Don't forget that white matter runs through deep gray, so you can have these lesions as well. And imaging can lag behind the patient for pretty much any inflammatory lesion we're going to talk about. And MS is one of the things to have on a differential diagnosis, typically a completely different clinical presentation as well. So don't forget that deep gray can be involved there. Radiation effect can certainly cause a lot of edema. Some portion of this could be related to tumor itself, but you're going to think about the brain swelling up. And we've seen, I'm sure you've seen cases where it could be hyperacute swelling or it could be acute swelling, that kind of stuff. In general, you know, you're going to think about a couple of things. One is to try to figure out if it's within the radiation port. I've always found it interesting that the clock starts at the end of treatment and the maximal effect is about 6 months after the end of treatment, which is kind of interesting, but it can be for essentially forever. It could be for a long time. It could be later on. I find perfusion to be super helpful for differentiating radiation effect versus other stuff. And it just makes sense to me that radiation necrosis would have little or no perfusion as compared to tumor or other things. And oftentimes you're going to have a mixture, right? You've got tumor, you're trying to necrose it. It would make sense to kind of have those together. So circling back around to vasculitis, vasculopathy, sort of a classic look, again, white matter process, clustered. If I showed you some microhemorrhages, that would be more suggestive of it as well. This enhancement pattern, there's intraparenchymal enhancement as well as some leptomeningeal enhancement. The morphology of this enhancement is sort of like cotton wool, so to speak, for lack of a better analogy. But generally, when I see white matter disease, like considerable white matter disease, whether it's clustered or not, but especially clustered, and then I see microhemorrhages, this is one of the things I'm thinking about. In terms of diagnosing vasculitis, vasculopathy, one of the things to remember is you can have normal MRA, you could have a normal CTA, you could even have a normal catheter angiogram. Now, when you see something, classically the appearance is going to be a beaded appearance or a dot dash appearance. And of course, the main differential diagnosis for that is intravascular or angiocentric lymphoma, which is mercifully rare. If they're going to go on to make the diagnosis of vasculitis, vasculopathy, one of the things to talk with your neurosurgeon about is the idea that if they're going to go on to a brain biopsy to make that diagnosis, they probably want to get some meninges, because sometimes the diagnosis is one of the ones that, you know, they need the meninges to make the diagnosis. So you can be helpful with that as well. Another inflammatory process, sarcoid, so neurosarcoidosis, can have pretty much any kind of appearance. When I was a resident, this was on the list of things that could be, it could affect any body part and it could have a whole lot of different appearances. But this is more of a classic appearance where you have these enhancing nodules along the surface of the brain, classically undersurface of the brain, with the primary differential diagnosis of TB. You probably have heard that or seen that several times. So the idea is that's one of the things, but in somebody with known or suspected sarcoidosis, this is definitely, you know, suspicious for neurosarcoid. And this you can have intraparenchymal disease, you can have secondary edema within the brain because of the leptomeningeal disease and that kind of thing. Now, classically, it's going to be T2 dark, and classically, it's going to extend along perivascular spaces. So those things can be helpful, but they're not definitive in terms of like making sure that it's not something else. So, of course, there's a differential diagnosis for this case, but you have to think about that as a consideration. Lupus can show up in different ways. You can have thrombosis of veins or arteries, that kind of thing. You can have a lupus vasculitis vasculopathy. You can have a lupus encephalitis. Again, non-specific, a lot of white matter disease here, secondarily involving the cortex, multifocally involving bilateral cerebral hemispheres, a little more on this side than that side. You could maybe wonder, is there a border zone involvement as well? But, you know, getting the history, knowing about that is helpful. You can think vasculitis, vasculopathy, again, with the other findings that we saw before. One of the times I think about it in particular is when there's sort of a paradoxical combination of bleeding and thrombosis. And don't forget that arteries and veins can both be affected. It's good to carry around the differential diagnosis for a miliary pattern. So this is a miliary pattern, and here's some of the things. Whenever you get into a tough spot and you're trying to figure out what something is, don't forget your categories of disease. You basically have to memorize some sort of mnemonic and go with it. I like CINTV, congenital, infectious, inflammatory, neoplastic, traumatic, and vascular. So just make sure you run through those in your mind and think about those. And that will help you remember to think about infectious etiologies, and then subcategorize it as, you know, sometimes they're parasitic and sometimes bacterial and so on and so forth. Here's a patient with Behçet's. in sort of a classic vasculitis vasculopathy look, after I show you several of these cases, you probably are starting to see, if you've never seen this before, kind of that amorphous sort of clustered look of enhancement, which is more typical for this. Is it pathognomonic? Sure, it is not. You know, like, I don't believe in pathognomonic anyway, but basically it's definitely something to consider and to lean on the gradient to figure out what's going on there. There are all sorts of things that can swell your brain, give you edema patterns within your brain. Here are a few of them. It's sort of a toxic metabolic sort of concept. Here is a patient with very severe liver failure and very severe brain swelling, cerebral edema. Whenever I read a head CT or a brain MRI on somebody who has known or suspected liver failure, I try to mention whether the patient has brain swelling or cerebral edema, because I know that matters in terms of them trying to figure out, are they on a transplant list, or have they received a transplant, stuff like that. So there's things they want to know. Classically, the T1 hyperintensity within the basal ganglia, think about manganese deposition, other heavy metal deposition, so hepatocerebral degeneration, like that kind of thing. And there are some other things to kind of look for here as we go through it, but for the sake of time, I will move on. All right, so continuing on the toxic metabolic stuff, here's a patient with cyclosporin toxicity, again, white matter process, and you've got sort of that curvilinear, slightly full sort of volume, like that kind of stuff. If the basal ganglia are involved, deep gray structures are involved, basal ganglia, thalami, that kind of thing, I like to use a mnemonic, toxic, metabolic, anoxic, hypoxic, like one big long word. And if I think about one, I try to think about the other three. Here's a patient that had a suitable history, that this fit with cyclosporin toxicity. It's not lost on me the seriousness of coming up with this diagnosis, because of course they may give them a drug-free trial, and that may be an issue, right? Somebody's had a transplant, and that can be very serious. You might say, well, this overlaps PRES, and that's classically when you start to think about cyclosporin toxicity as well. Speaking of which, this more classic appearance of PRES, and any of the words in this can be false. Posterior reversible leukoencephalopathy syndrome, any of these might not be true in a particular patient. They can bleed, they can enhance, like that kind of stuff. Classically, enhancement characteristics for inflammatory lesions, they could be anything, so it could be solid, like you've seen for the vasculitis vasculopathy. It could be peripheral, like for MS. There are a lot of different ways it could be. It is not so common for inflammatory lesions to be non-enhancing, so that's not so common. But for different patterns, you can see it. And of course, there are a lot of different things that can cause PRES. Some of them are listed there. Look for corollary findings to help your differential diagnosis. Look for obscuration, in this case, obscuration of the gray-white differentiation. So this patient's brain is swollen, clearly. Soul sign cisterns are faced, but also there's obscuration of gray-white. So that would be cerebral edema. And this is a clinical diagnosis, but this patient was in this status at that time. So look for other things to help your differential diagnosis. So when I'm looking at a case, I go as far as I can on what I see on the screen, and then I want to understand what I'm looking at. If I still don't understand it, that means I need more input if possible, like old scans, or talking to the referring physician, talking to the patient, maybe blood results, that kind of stuff. And like I said, the chart biopsy can be very helpful. So once you get corollary findings, that can help hone your differential diagnosis. And like I was saying earlier, this is an appearance of vasogenic edema. You get the idea there must be an underlying lesion, and you can kind of make it out right here. There's a mass right there, and relatively less intense on the flare. And this is a reaction to that. Are there tumor cells in here? If it's lymphoma, maybe there might be some. If this is a glioma, then there probably are. If this is a metastasis, there probably aren't. Just in terms of like thinking how those things put together. If you don't think about inflammation, you might not come up with it as a possibility. So every time you think about infection, every time you think about neoplasia, think, could this be some sort of inflammatory process? Also, on the flip side, just because somebody's septic doesn't mean that whatever you're looking at as an abnormality is infectious or inflammatory, that kind of stuff. It could still be neoplastic. There's some overlap as well as that goes. Don't forget about subacute infarcts. They can be the initial presentation. The patient may have had an infarction, say the frontal lobe here. This probably would have been evident clinically and shown up earlier, but imagine, you know, it wasn't, maybe on the other side, could have been clinically silent or, you know, that kind of thing. And then they come in later and then they have what looks like, you know, mass, right? With some positive mass effect. And maybe you're worried that it's neoplasia or infection or inflammation. It might partially enhance. It might be in that subacute phase and enhance. So again, short interval follow-up to resolution of abnormal enhancement, stuff like that can be very helpful to make sure it's not something more sinister. And generally, Elster's rule of threes helps you remember when to do it. Enhancement of subacute infarct as early as 3 days, maximum at 3 weeks, gone by 3 months. Then try to get people to wait 3 months, and if they can, if the clinical situation allows. I mentioned cerebellitis earlier. Here's a case of cerebellitis. Unknown etiology, I think, in this case, but usually VZV is the one that's attached to this. Usually a childhood illness, but it could be many things as well. So probably infectious. Don't always find an etiology. I think, you know, last time I looked at unknown etiology there, but kind of thinking about that. And of course, for those of you who read a lot of neuro, remember that any kind of posterior fossa mass effect, you worry about hydrocephalus and worry about herniation and stuff like that. Like I said earlier, corticosteroids can reduce all sorts of things, including swelling, edema, enhancement, that kind of stuff. Here's a patient with HIV encephalopathy. Volume here is about neutral. So finishing up here, if you think these two may look a lot alike, infection and inflammation, you're right. So whenever you think about one, think about the other. Try to figure out what the history is for this patient and see how it fits into helping you take care of that patient. It may help hone your differential diagnosis. For example, remember, like I said, with Edema, the patient should be encephalopathic, for example, and have that. So many times things are going to be non-specific, but sometimes there are some characteristics that help you suggest a possible etiology. For example, harkening back, if you see clustered white matter lesions and some microhemorrhages plus minus enhancement, think vasculitis, vasculopathy, and that's something that can be helpful. All right, thank you very much for your time. I will try to answer questions on the Q&A session. Thanks.
Thanks so much, Mark. Really, really beautiful cases there and some great pearls for the residents. So thank you.